First story, he was at one hospital, and then he checked himself out to go get a second opinion. But part of the reason he checked himself out of that hospital to get that second opinion is because he lost confidence in the medical team taking care of him. Because at that time, they were doing all these tests, and they were talking directly to the Celtics physician, not to the patient and his family. And of course, it's going to involve his career. He wants to be part of that decision making, right? So he checked himself out. And if anybody's from the Boston or New England area, Brigham and Women's is actually a very world-renowned facility, hospital, pretty advanced medically. So it wasn't like he went from a first-rate hospital to a third-rate. He actually went to one of the best hospitals in Boston. And then that team of doctors were like, well, maybe he can still play. So he went and he was going to do a charitable basketball game there in Boston, and he was just warming up and then collapsed and then died from this incident. So just kind of a highlight of one, HIPAA, right? But two, involving your patient in their own medical decision making, right? Because imagine this outcome could have been very different if the initial team of doctors actually were talking to him directly instead of talking to the Boston Celtics team physician, who of course has the loyalties to the organization, not necessarily to the player. So he felt like he lost that advocacy, unfortunately, and felt like he had to get that second opinion, and it ended up costing his life. So, but kind of as we talk about cardiomyopathy today, kind of see how and why this could have happened to such a young athlete at the pinnacle of his career. So. Let's do a couple of check-on learnings before we start delving into the topic for today. So our first one is a 72-year-old woman presents with dyspnea on exertion, labored breathing while lying in bed, and severe breathlessness that awakens her from sleep at about 2 a.m. each night. Which of the following would be more suggestive of heart failure with preserved ejection fraction than heart failure with reduced ejection fraction? What are your thoughts on this? C, I'm hearing C. Would you agree with that? Yeah, I'd agree with that as well. So remember, preserved ejection fraction is a diastolic dysfunction where there's a filling problem to the ventricle, whereas HFrEF is a systolic dysfunction where you just can't eject or get rid of that blood that's in the ventricle. What ends up happening is you eject with preserved ejection fraction. Whatever blood gets into the ventricle, you're going to get rid of it because you have a powerful squeeze of that ventricle. So you're going to get rid of it. But the problem is you're just not getting rid of the adequate volume there because the ventricle itself can't handle an increased volume. S3, remember that's a volume overload finding, so that would be more indicative of HFrEF. Increased left ventricular and diastolic volume on echo. That is going to be, again, HFrEF, because remember, there is a volume problem. You have decreased volume in HFpEF. And then mortality reduction with angiotensin converting enzyme. That is something that you can see in both, although the evidence in HFpEF is still kind of coming in, but we definitely see it in HFrEF. So, but seeing that, you can't say that that is more along the lines of HFpEF. So that's why Charlie is the correct answer on this one. Our next one is a 64-year-old man presents with shortness of breath, orthopnea, and lower extremity swelling in the recent months. Examination is notable for jugular venous dissension, bibasilar crackles, and S3, and symmetric pitting edema. So you have both left side and right side heart failure symptoms. Echo is performed and demonstrates a left ventricular ejection fraction of 30%. Which of the following medications would improve survival when administered chronically? What are your thoughts? Remember, which ones of these classes have a mortality benefit in heart failure? beta blocker, so metoprolol, so A. Remember, furosemide, so the diuretics, although it helps with improving symptoms, does not have a long-term mortality benefit associated with it, because it doesn't do anything as far as regulating that adverse cardiac remodeling that oftentimes happens in this condition. So, correct. Okay. Good. So, let's start our talk about cardiomyopathy. So, what exactly is cardiomyopathy? The loose definition of it is a diverse set of heart muscle disorders that affect myocardial systolic and or diastolic function. Okay? So you can see at the bottom, there's a little caveat that says you have to exclude from this definition any group of disease resulting from other cardiac conditions, so like hypertension, valvular diseases, coronary arterial disease. So basically, the other pathologies that we talked about don't get lumped in under the umbrella of cardiomyopathy. And there's a lot of different kind of versions of this, but the three main types that we're going to talk about today, because the PANCE requires you to have that mastery of this, is dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. With these, they're not all the same. There's a different pathophysiologic thing going on in each of these, and you can kind of branch these or define these into which one causes systolic dysfunction, so dilated cardiomyopathy, and which ones cause diastolic dysfunction, so hypertrophic cardiomyopathy, restrictive cardiomyopathy, kind of fall under that subset of conditions. So kind of understanding which ones go where kind of helps you understand what's the pathophysiologic condition that's going on that causes the heart not to function properly. So let's start looking into these individually. We're going to start with dilated cardiomyopathy, so the systolic dysfunction. There's a subset one that we're going to talk about, which is stress-induced cardiomyopathy. And then we'll finish up with hypertrophic and restrictive, the diastolic dysfunction cardiomyopathies. So dilated cardiomyopathy is basically a dysfunction of the heart and the myocardium that leads to a dilation of all four chambers of the heart. You can see on this picture here, on the right, this is what a normal cross-section of a heart would be going through, like the right ventricle and the left ventricle. You can kind of see the left has a large band of muscle around it. Imagine the power to the squeeze that can generate, right? Compare that to your left, where this is now a cross-section of a patient who has dilated cardiomyopathy. And you can see how much bigger the right ventricle and left ventricle volume is, but also look at how thick the band of muscle going around the left ventricle is. Imagine how much less powerful of a squeeze that can generate, because you're stretching everything else. Like that rubber band that's stretched too far, it's not going to be able to hold as well as a rubber band that is not stretched out and damaged, right? So, unfortunately, this is somewhat common in the United States. About 10,000 deaths a year and 46,000 hospitalizations in the United States alone. And what's interesting is this dilated cardiomyopathy is the most common primary indication for cardiac transplant. So unfortunately, when somebody develops this, it permanently damages the heart and the heart function to the point where they need a new heart. And you can see most of the time when we talk about cardiac disease, we normally are thinking like, 60s, 70s, 80-year-olds, the elderly populations are the ones at risk. But look at the age range for when this typically develops. 20 years old to 50. What's our patient population going to be with our active duty?
20.
Correct. So this is going to be your patient population that's going to be susceptible to developing this condition. And there's lots of different kind of causes to it. So there's, yeah, we have no clue. That's of course the most common, unfortunately. But you can look at this list. How common are things like Coxsackie virus? How common are things like parvovirus? How common in our active duty is alcoholism? Alcohol toxicity can cause this. Fortunately, if it is due to alcohol toxicity, if they start to abstain from alcohol, they tend to get better from this. So this actually is a reversible cause of dilated cardiomyopathy. But you can see these are so common in our society, and it's the age group that we're going to take care of. There are some other causes, so peripartum cardiomyopathy. You have a young mother or soon-to-be mother in her third trimester who all of a sudden starts going into heart failure, and her life is at risk, and so is the baby's. Now, if they can survive through that initial insult, a lot of times the heart will recover. However, if they had it happen once during a pregnancy, what are the chances that it's going to happen again with a subsequent pregnancy? So if they survive that initial time, one of the counseling points you have to have with that mother is don't get pregnant again or else it could kill you next time. Not an easy conversation to have. And then stress cardiomyopathy, we're going to talk individually because that is a common and kind of a unique kind of situation with this. So when you have somebody who develops cardiomyopathy, dilated cardiomyopathy, you really kind of have this cascade of events that leads to the pathophysiologic condition that you see. So you get that myocyte injury. Well, it's not going to contract as well. It's not going to squeeze. You're going to lose that systolic function. That's going to lead to my cardiac output dropping. So my stroke volume drops, which means my cardiac output's going to drop. Now I start to have all this extra blood staying around inside that ventricle. That's going to cause my ventricle to dilated cardiomyopathy, right? But remember what we talked about when we were talking about mitral regurg, and this even can go to tricuspid regurg too. But what's one of the causes of secondary mitral regurg for tricuspid regurg? It's the dilation of the chambers. You pull those leaflets apart because that muscle, those walls start to get pulled apart because of that dilation, and now they have mitral regurgitation. We talked about how if you have an acute mitral regurg, then that can lead to death pretty quickly, right? And unfortunately, that can also then lead to this condition getting worse too, where now those ventricular filling pressures start to go up because now you're having all that blood that should be leaving the left ventricle or leaving the right ventricle, staying there or coming back because of that regurgitation, and now that dilation is going to get worse. So now you have increased volume, increased pressure accumulating in that. And it can lead to the compensatory changes. The body's going to try to overcome the problem. But we remember when we talked about with heart failure, a lot of the compensatory changes actually have a negative effect on the overall function of the heart. So ventricular heart disease develops as the ventricles dilate. The mitral regurg occurs because of that dilation and pulling those leaflets apart. That can lead to other problems. That dilation then can lead to putting extra tension, stress on the conduction system, which then means you have arrhythmias developing because of this. And that in and of itself can then lead to death when you have these sudden development of arrhythmias that either are fatal themselves or it impacts the function of the heart so much that it can't support life. Don't memorize this chart of all the different types of etiologies of dilated cardiomyopathy, but look at some of the common things that can cause this. So infectious, we talked about that, great. Bacterial. You have deposition diseases like hemochromatosis and amyloidosis. You have medications. A lot of these are chemotherapeutic type of medications, but there are some other ones. There's toxins like alcohol or cocaine, amphetamine overdose, electrolyte abnormalities, nutritional deficiencies. So the list of things that can cause dilated cardiomyopathy are not, down to one thing. It could be virus or infectious. It could be medication induced. It could be toxin induced. It could be nutritional induced. So lots and lots of things can cause dilated cardiomyopathy. When you're going to have a patient, or when you're going to diagnose a patient with dilated cardiomyopathy, it's important to do your history and physical because you're looking for causes. You want to see if there are any reversible causes to their condition. So ask them, don't be afraid to really press them about alcohol consumption or cocaine and amphetamine misuse, because those could be reversible causes, and just by simply getting them to substance rehab, maybe we can save their life without the heart transplant. Other things like, okay, if they've had cancer before and they've had chemotherapy, maybe we need to change up their regimen to something that doesn't have this effect, but probably more inclined that this is going to be permanent damage, and maybe we need to be pursuing a heart transplant sooner rather than later. So what are they going to look like, or how are they going to present to you? So remember the age range, so a younger population coming in complaining of heart failure, particularly like left-sided heart failure type symptoms, so crackles, pulmonary congestion, poor cardiac output, so exertional dyspnea, feeling faint or weak or lightheaded with exertion because you don't have that cardiac output in order to support that exertion. And then when you do your physical exam, it's going to look like heart failure. You're going to hear those crackles. You're going to see that peripheral edema, and that should make you think of cardiomyopathy. Because remember, from a heart failure standpoint, the most common cause is coronary arterial disease, right? Heart attacks and those types of things. This is the age population that we typically don't traditionally think of as having coronary arterial disease, unless there is a genetic condition that leads to the premature development of the condition, right? So somebody who doesn't have risk factors for heart disease comes in like this, be suspicious for dilated cardiomyopathy. On your ancillary studies, what is it going to look like? Well, your EKG is going to be showing you some non-specific changes, but it's going to show you changes. So things like left axis deviation, left atrial enlargement, left ventricular hypertrophy. It's going to maybe show you some arrhythmias developing, left bundle branch blocks, right bundle branch blocks, maybe even first degree AV block, re-entry tachycardias, which hopefully they're not presenting to you in that state because that's an acute physiologic change that can lead to pretty severe outcomes if it's not treated well enough or quickly enough. But you can find a lot of different kind of things, arrhythmias and the chronic changes of the chambers present on your EKG. Echo is going to be your test of choice, and you can see with echo, you're going to see this with somebody with true dilated cardiomyopathy. You're going to see 4-chamber enlargement with little concentric hypertrophy. So remember, concentric hypertrophy, when we talked about that in the first heart failure lecture, was where you get the stacking of the myocytes in order to try to get a much more powerful squeeze, right? You're not going to see that in this because the problem is more of an elongation, a dilation. So you may see eccentric hypertrophy, so the lining up of those myocytes to make them longer. So you may see that. You're going to see, because this is a systolic dysfunction, you're going to see that that ejection fraction, that EF is going to drop below normal. And then also on echo, you may see the evidence of that mitral or tricuspid regurgitation from that dilation of the chambers. Chest x-ray, just going to show basically the whole heart is enlarged. It's not localized to one specific chamber or one specific side. All four are going to be enlarged. Other studies that you can do are doing a heart cath to try to assess the pressures that are going on inside of the chambers themselves, because this is going to help you with kind of the prognosis and maybe even how aggressive we need to be with our treatments at that point in time, depending on what those filling pressures are. The other thing that can happen is, let's say I'm suspicious that this is like hemochromatosis or amyloidosis, or even a sarcoidosis. I can do a biopsy at this time to kind of help me determine the cause of their condition. Now, if it's like Coxsackie virus and you have a positive titer for Coxsackie, do I need to do that biopsy? Absolutely not. It's more this biopsy is indicated if you just don't know what is going on or what caused this condition to develop in the first place. Other things you can do, cardiac MRI, great. PET scan, if you are suspicious for sarcoid, can help you with the diagnosis, but those may not have as much of a benefit unless it's like a specific population that you're looking at. The labs, there's not a set of labs you should do for this. Yes, sure, do cardiac enzymes, sure, do a pro-BNP, BNP, depending on what your facility has, to look at the measure of failure, heart failure that's there. But as far as like other studies, maybe not as useful. Maybe tailor it based on what you suspect is the cause. If you suspect it's a viral thing, then sure, get a viral panel to test for it. If you suspect it's hemochromatosis, do iron studies. If you think it's thyroid disease, do thyroid. But you don't necessarily just shotgun and order all of these tests just for the sake of that. When we go to treat somebody with heart failure, we want to do one of four things. So we want to treat the heart failure symptoms, so that excessive volume overload that they have, right? Let's treat those things. Let's prevent them from developing that arrhythmia that could kill them acutely. Let's prevent them from getting thromboembolic disease. So let's prevent that clot from forming because of that static kind of blood flow, because the heart's not injecting and not moving the blood efficiently. Let's prevent that clot from forming and then getting sent to the brain and causing a stroke, or getting sent to other peripheral arteries and causing your 6 Ps from happening. And then ultimately, if this is not due to a reversible cause, then they need to get put on the cardiac transplantation list, which could take a long time for them to be found to be a match, unfortunately. So how are we going to achieve these 4 goals? So, we said cardiac output is a problem. So how can I improve my cardiac output? Do I want to speed up the heart rate? Not necessarily, right? If I speed up the heart rate, I increase my metabolic demand. And if I'm already not circulating blood flow well enough, then that can be counterintuitive and actually make this condition worse. So let's look at ways that we can increase our stroke volume then. So if I have a volume overload state, so I have that excessive preload, let me start to tackle that problem by giving diuretics or doing salt restriction to reduce that volume. Maybe I can support that circulation and that return of blood from the legs back up to the heart. So the heart doesn't have to work hard to get that blood returned. So let's do like compression stoppers. Okay? Prevent that pooling of blood, prevent that risk of developing clots, DVTs, that then can even add additional stressors to this diseased heart. Let's look at reducing our afterload. So your ACEs, your ARBs, and even the ARNIs are actually good at doing this. Because not only does it reduce the afterload, but then it also has, remember, all those mortality benefits associated with reducing that adverse cardiac remodeling. And then let's maybe give digoxin to help increase that contractility. So now I have a much more powerful squeeze, even though this heart maybe can't generate an adequate squeeze on its own. That was how to improve the cardiac output by increasing or improving the stroke volume. But how can we manage that dilation? So we said that dilation is a component of this disease. What's to say that that dilation is not going to continue to get worse, which means then an even further decline in my function? So how can I prevent that dilation from occurring or getting progressing and getting worse? And the way you can do that is, well, let's first manage your arrhythmias. So if I have an arrhythmia develop, I will significantly impact that cardiac output, which then can lead to further decline in my EF, more blood at the end of systole in the ventricle, which is just going to dilate that. So maybe something like amiodarone can prevent those arrhythmias from developing and contributing to that decline in EF. The cardiac remodeling. So there is going to be compensatory changes developing in this diseased heart. And again, remember, these compensatory changes don't necessarily do the best thing for the heart to actually improve the symptoms. So let's give them things similar to what we saw for treatment of heart failure, HFrEF particularly, to help reduce this adverse remodeling. So ACEs, ARBs, ARNIs, aldosterone antagonists, beta blockers, all of those things will minimize or stop that adverse remodeling. Anticoagulation, so preventing the blood clots. So maybe giving them warfarin, maybe a DOAC, maybe even if they're okay with doing injections, doing your low molecular weight heparins to prevent that blood clot from forming in the first place and causing further disease with this. And then if none of those things are helping, you still have that depressed function, then we may need to do mechanical circulatory support devices like the LVAD, the left ventricular assist device, or put them on the heart transplant list. But again, that's going to take a long time to get that transplant done. So what's the prognosis for somebody who has dilated cardiomyopathy? Ultimately, it's going to depend on what the actual cause is of their condition. If they have peripartum dilated cardiomyopathy, then the majority of patients will recover. So there's nothing that we really need to do other than, hey, probably not a good idea to get pregnant again because it may kill you. If it's a viral thing, okay. If it's alcohol-induced, again, a reversible, potentially a reversible cause of cardiomyopathy. But ultimately, when you look at the prognosis, in men, median survival is less than 2 years after they've been diagnosed. And to be honest, they are unlikely to get a heart transplant within 2 years. Women, it's a little more, you get a little longer, 3.2 years, but I suspect that's because of the peripartum cardiomyopathy, where folks can recover from it and live a normal lifespan with it. So that's probably the only reason you see that improved prognosis in women compared to men. Either way, this is not a disease to have because you don't have much longer to live if you develop it. Well, let's look at stress-induced cardiomyopathy or stress cardiomyopathy, because this is kind of a subset of dilated cardiomyopathy, but there's a unique thing that causes this. This is not a virus. This is not a medication. This is not a deposition disease or anything like that. What actually tends to cause this is having such a severe stress or emotional stress reaction. The typical patient is that new widow who comes in with heart failure, maybe even a heart attack. Because of that extreme grief reaction to the death of their spouse causes them to have this severe stress response leading to the development of this condition. So on your boards or on your standardized tests, the classic example of this is that new widow coming in with heart failure. And they're going to come in, and fortunately, if you can get them through that acute phase, they should recover. Maybe not back to 100%, but they should be able to go back to living the lifestyle that they had before the event occurred. But in that acute phase, you can look. They're going to have heart failure. They're going to have arrhythmias developing. They're going to have hypotension, and they can even have cardiac arrest from this. So it's not a, oh, it's whatever, it's just stress-induced, they'll be fine. But there is an acute phase that needs to be managed actively, or else they could die. The nice thing is, if you can get them through that acute phase, then they may be able to recover, or they are likely to recover. Another word, or another term, there's a couple of different terms for stress-induced cardiomyopathy. There's broken heart syndrome, probably the most common one you've heard. There's apical ballooning syndrome, and that's because that's what we typically see on echocardiogram. But Takotsubo's is another term for it. I used to think that Takotsubo's was just the name of the scientist who, or the physician who identified this, but actually Takotsubo is the Japanese term for this octopus trap. And you can see, what you see on echo is you see this apical ballooning of the left ventricle, so it makes it look like an octopus. And oh, by the way, you have the little tentacles kind of coming out looking like that. So that's why it's called Takotsubo's cardiomyopathy. But these are all the same. Broken heart syndrome, stress-induced cardiomyopathy, apical ballooning cardiomyopathy. They're all the same with Takotsubo's. So what are you going to see on echo? So you're going to see typically this ballooning, or this enlargement of the apex of the heart. And you're going to see like wall motion abnormalities in this area because of this. It may even look like they have like a heart attack going on, but the wall motion abnormality doesn't necessarily fit a specific coronary artery distribution. So you may have it where it looks like you have the LAD is affected, but then that's weird, there's a little part of the right coronary also. This doesn't make any sense. So you may see that. But the treatment for it is, one, to treat the acute symptoms, give them that time for their body to recover from this, and then maybe because they had such a severe reaction, an emotional reaction that triggered this event, maybe we need to consider putting them on anti-anxiety medications or antidepressant medications so they don't have another severe reaction like this. Particularly things like birthdays, anniversaries of death, holidays, tend to bring about such a severe reaction again, similar to as if that loved one just died. So that's why maybe we need to be giving them medications to prevent this from happening again, because there's going to be multiple times down the road where that wound is going to be reopened. Okay. So that's our dilated cardiomyopathy, and that was our only form of a systolic dysfunction. Okay. We'll start our next one, a hypertrophic cardiomyopathy, before we take our break. But this is now the next two cardiomyopathies that we're going to talk about. These are diastolic dysfunctions. Okay. We didn't really spend a whole lot of time talking about diastolic dysfunction from a heart failure standpoint, but in cardiomyopathies, kind of the primary ones, or the more common ones, are actually diastolic dysfunctions. Okay. This is the form of cardiomyopathy that Reggie Lewis had from the story that we opened up class with. Okay. With hypertrophic cardiomyopathy, you may have heard of it also as hypertrophic obstructive cardiomyopathy, HOCM. It's two different things kind of going on, which we'll talk about when we look at the pathophysiology of this condition. So we're just going to do like the big umbrella, which is hypertrophic cardiomyopathy. Okay. And typically with hypertrophic cardiomyopathy, you're going to have an enlargement or a hypertrophy of the myocytes, or the myocardium, but localized to a specific area. This is not like left ventricular hypertrophy where the whole ventricle myocardium is enlarged or hypertrophied. This is going to be localized to a particular region. And in this case, the most common is the interventricular septum becomes hypertrophy, which you see in this picture here, where you have the normal thickness of the left ventricle, but look at how thick this interventricular septum is. That should not be that thick. It should be probably about a quarter of that size in a normal heart. This is super common. 1 in 500 adults has this. It's the most common genetic cardiovascular disease, unfortunately. There are some conditions particularly that can cause this, like Friedreich's ataxia, but it doesn't necessarily fit like a certain demographic. It affects everyone, basically. And when we look at what pathophysiology, or what's going on, you can really kind of divide this in half, okay? And this is why we have the term hypertrophic cardiomyopathy, because that just refers to this side, the left side of this flow chart, where you get this enlargement of the fibers that can then lead to arrhythmias developing, which then leads to either sudden death or syncope because you're not perfusing organs properly. You get that LVH that develops, which leads to a diastolic dysfunction, which then can lead to pulmonary congestion. So you get the shortness of breath and crackling and all that kind of stuff. But if they have the obstructive component to it, that outflow of the left ventricle through the aortic valve and into the aorta can become obstructed to the point where you have little to no flow actually leaving the left ventricle. And this is where you get like that sudden passing out, in addition to the arrhythmias that might develop. But you're active, you're running, and all of a sudden that outlet occludes, and now you get no blood flow out with that, and you get a temporary perfusion deficit that can lead to a syncopal episode or even a near syncopal episode. But then there's another component to it where this can cause mitral regurgitation, and you may be wondering, well, how in the heck does that happen? Do I have any engineers in here? I was not an engineer. I hated physics. But the Venturi effect comes into play here. And what happens in the Venturi effect is when you have flow going through a pipe or whatever, it's high pressure, but then you get a narrowing. Now that speeds up the speed by going through that narrowing, but by doing that, it actually drops the pressure. So you develop a low pressure environment as it narrows down like that. And what happens when we see it in the heart is that narrowing, because of that septal hypertrophy, it goes through that narrowed area, it creates that low pressure environment, and what ends up happening is the anterior mitral valve leaflet gets pulled towards that septum. So it actually opens the mitral valve when the mitral valve should be closed. So now you're getting a regurgitation because that valve is open. At least one leaflet of the valve is open. But then if that movement of that mitral valve is bad enough, it actually can completely occlude that outflow from the left ventricle. So all of the blood that should be going out to the aorta before that closed ends up going into the left atria. And I'm going to show you an echo from one of my classmates from med school who went into family medicine, and then he did a fellowship in hospitalist medicine. But part of their program, they teach a lot of point-of-care ultrasound to the point where they become really experts on this. They can diagnose all kinds of things. But he presented this echo at a conference I was at earlier this year, and he sent me the video of it. But you can see how significant this obstruction can be. So this is just a still of it. So you're going to see this little mass here. This is your septal hypertrophy. This is supposed to be your aorta. You kind of see some fuzziness here. That's your aortic valve. Here's your mitral valve, left atria, left ventricle. Okay. Oh yeah, sorry. Let me get laser pointer here, bigger. So here's your left ventricle right here. Here's the septal hypertrophy. Here's your aorta with this little haziness being the aortic valve. Here's your mitral valve and your left atria, okay? So look at this. Take my laser pointer off. Let's take a look at this echo now in real time. So here is your outflow to your aorta. So you see there's a little bit right there, right? That looks good. But, oh yeah.
Kiss the mouse.
Okay. So here's your outflow to your aorta, aortic valve. Here's your left atria, mitral valve. But let me try to freeze this just a smidge of a second earlier. Here. So here is the Venturi effect in full action. That mitral valve leaflet is completely occluding that outflow to the aorta. And you can see it is wide open now, and all that blood that was remaining in the left ventricle is getting sent to the left atria instead. So that is why this becomes an issue for our patients. So
that is caused due to the low pressure that it generates?
Correct. Yep. So that flow, that outflow, systolic flow of blood going to the aortic valve, aorta, gets through that narrowed area. That pressure drops, and it kind of is like a vacuum, and it just pulls that anterior leaflet of the mitral valve to the septum itself. So, but, yeah. Okay. I ran 3 minutes late, so let's go ahead. We'll come back at 9:03. And mitral valve can get pulled down and occlude that left ventricle outflow tract. But let's look at histologically what happens to the muscle, which can also kind of help us understand why we see what we see in these patients. So typically, when you have left ventricular hypertrophy, so the whole myocardium in the left ventricle becomes enlarged, there still is an organized pattern to how those myocytes are laid down. So that it still leads to ultimately having a normal function, normal flow of blood and everything like that. But when we have hypertrophic cardiomyopathy, look at how this is layered down. Plus you get all the other stuff deposited in it. But there is no stacking, there's like cross-linking and everything like that. And that can further harm the actual function of the left ventricle, because now you don't have that band-like squeeze to squeeze that blood out of the left ventricle and up through the aorta. You're kind of getting that cross-linking, and it just kind of disrupts the normal squeeze and that normal one-directional flow of blood, unfortunately. So it's a very disorganized enlargement of the myocytes. So how are your patients going to present. Think about Reggie Lewis. He was in his early 30s, right? Had never had any problems before. Even though he was at the pinnacle of his athletic career, he not only had gotten through JV basketball, varsity basketball, college basketball, he'd been playing pro for a number of years before he had his first symptom. And so these folks tend to be asymptomatic or have a prolonged state of no symptoms. But when they start to have symptoms, think of things that can lead to a reduced cardiac output because of that outflow obstruction that can occur. So dyspnea on exertion. Okay, well these are athletes. Is it because of this, or is it because they've been pushing themselves and maybe they're not in as peak physical shape as they should to be able to compete at that level? Fatigue, chest pain, pre-syncope, syncope, arrhythmias, and of course sudden cardiac death. So you could go from asymptomatic to sudden cardiac death without warning from this. But if you were to appreciate something on physical exam, what would you see? Well, one, you're going to have a crescendo, decrescendo kind of murmur that's best heard at Erb's point. Okay, so best heard at Erb's point. Kind of think of this as an aortic stenosis murmur, but not at the aortic auscultation site. It's going to be at the left sternal border or Erb's point, so one area down. And it is a systolic murmur. Okay. Now you may also hear if that mitral valve leaflet is getting pulled down because of that Venturi effect. You may also then get a holosystolic murmur, or indicative of like a mitral regurgitation. Okay, so there may be something else because of a consequence of having that septal hypertrophy. But the actual murmur, because of that septal hypertrophy, is going to be that crescendo, decrescendo murmur, best heard at Erb's point. The other thing that's kind of interesting is you can do the dynamic maneuvers, and you get a kind of an interesting result with it. So if I Valsalva, I create a positive intrathoracic pressure, I'm decreasing my preload, it makes the murmur worse. And the reason for that is if I don't have that preload there, I'm not pulling apart that anterior leaflet and the septum apart. So it's going to be closer together, which means then I'm going to have that turbulent flow increased even earlier in systole, because I just don't really have much volume there to kind of keep those two entities apart. If I squat, and now I'm getting that venous return coming back, and oh, by the way, I also increase my afterload. Now I've got that pressure kind of being exerted downward into the heart. It forces those two entities, the septum and the mitral valve, to be pushed apart. So now, because those areas are pushed apart, it becomes softer because I have less of a turbulent flow. So with your dynamic maneuvers, you can help diagnose this condition. Ancillary studies, EKG. Yes, you may see like left ventricular hypertrophy on it. You may see like a left axis deviation. But one of the pathognomonic kind of findings on your EKG for hypertrophic cardiomyopathy is this dagger-like prominent Q waves that you see kind of with these arrows that I've put on the EKG. This is because you're detecting that depolarization of the enlarged septum. So you're seeing that. So if you see dagger-like Q waves, because these don't necessarily, remember when we talked about pathologic Q waves in myocardial infarctions, right? This doesn't necessarily meet the criteria for a pathologic Q wave. It's just an abnormal finding because they have this other condition going on. This is not that they had a heart attack previously and now they have Q waves. It's just how those leads are arranged and how we're detecting that ventricular depolarization occur. Echo is going to be your test of choice, of course, because you're going to be able to see that hypertrophy of the septum. You're going to be able to measure the degree of it, but you also are going to be able to detect that outflow obstruction. How bad is it? What's the blood getting around it? All that kind of stuff. So your echo is going to be important, but the key finding is going to be that asymmetric septal hypertrophy. Chest X-ray, you may see some things on it. You probably will not see anything. Your cardiac MRI may be able to help you kind of further measure, clarify what's going on. Really think of that being indicated for surgical planning, okay? But you are going to want to do a Zio patch on these patients because you want to detect, we said arrhythmias are a large component of this, and especially sudden development of these arrhythmias is important and can lead to death. Let's do a Zio patch to monitor to see if our patient is having arrhythmias coming and going, because that could influence when we treat, how we treat, or activity restrictions. How can we manage or how can we counsel these patients outside of doing surgery? Well, from a non-pharmacologic thing, what we can do is let's have them avoid volume depleted states. Let's keep that preload up so that I can keep those two structures separated so I don't have that obstruction occurring, right? So avoid dehydration. Make sure you're keeping hydrated. Maybe you don't want to go on salt restriction, right? With every other case that we've talked about so far, we say salt restriction, but that's counter to what we want to occur in this case. Let's avoid overexertion, and there's a reason for that. With overexertion, I get my heart rate up. What's going to happen to the diastolic filling time? It's going to drop, right? If I drop my diastolic filling time, now I'm not getting the blood, I'm not getting the preload necessary in the ventricle, and now I'm having that ventricle collapse, which is just going to make this condition worse. So let's avoid things like beta blockers. I know we always talk about beta blockers are so great, but in this case it can make it worse. Same goes with the calcium channel blockers as well. So other things we want to do is we want to actually maintain afterload. So we don't want them on an ACE, we don't want them on an ARB, we don't want them on an ARNI, because I want to maintain that afterload. Because that afterload at least gives me that pressure coming from above to keep those two structures separated so I can actually get an outflow from the left ventricle. Let's decrease the contractility. So now you're like, oh, you just said don't do beta blockers, don't do calcium channel blockers, but maybe there's one that we can do that will decrease the contractility without having as much of an effect on the heart rate. Because by decreasing the contractility, think of it as my EF will go down a little bit. So instead of it being like 65% blood is ejected every time my heart beats, I put them on something that decreases their contractility. Now they have a 50 or 55% EF. Now that means I have more blood staying in the left ventricle at the end of systole to keep those two structures separated. You got to manage the arrhythmias with like an antiarrhythmic because those could lead to sudden cardiac death. And then ultimately, doing surgical septal myectomy may be required. So open heart procedure where I go in and I cut out that outflow area of the hypertrophied septum. So that's one way I could do it. The other way I could do it is I can maybe feed and do an ablation where I basically cut off the blood supply to that septum, and then that muscle atrophies and dies because it doesn't have that blood supply going to that area, which then will open up that outflow. So the conundrum that we have is, if this is common, 1 in 500 adults in the United States has this condition, and we need to avoid overexertion, we need to limit physical activity, how many athletes do we have, even just playing like JV or playing, T-ball or whatever? One of the things in the summertime that's going to occupy your time as a provider is going to be pre-participation physicals. You're going to learn about these a lot more in pediatrics next semester, but this is the only thing we have in order to screen for this condition. And unfortunately, it is inadequate because you may not detect those who are actually at risk of developing this condition. Because we don't have the resources like an EKG machine or an echo to be able to screen all of the 12 million athletes that are estimated in the United States. We just don't have those resources to devote to what is typically a healthy population, but is also a population that typically wouldn't be coming to see us in the first place. This is not just our sick populations coming in. This is 12 million more people that I need to drop into our laps in order to screen them for these conditions. And it's not really cost effective, unfortunately. But that leaves kind of a struggle for us as providers, because our hope is that we identify those people who have this condition so that we can prevent a death from occurring, like you saw in the video today, and like all the additional like pro athletes and stuff like that across all sports who die. So what is our screening going to look like? Well, we're going to do a questionnaire, and when you look at this questionnaire, you see, has any family member or relative died of heart problems or had an unexpected or unexplained sudden cardiac death before the age of 50? Does anybody in your family have hypertrophic cardiomyopathy, Marfan syndrome, arrhythmogenic right ventricular cardiomyopathy, long QT syndrome, short QT syndrome, Brugada, or catalytic polymorphic ventricular tachycardia? I imagine you're going to be asked by your patient, what the hell does that mean? Does anyone in your family have a heart problem, pacemaker, or implanted defibrillator? Has anyone in your family had unexplained fainting, unexplained seizures, or near drowning? Unfortunately, most of your patients are going to have no idea what their family history is. Oh, I don't know. We don't talk. I'm adopted, whatever. Like, they're just not going to know. So how are you supposed to take this screening in that case when they don't even know what their family history is? I'm trying to identify at-risk people based on family history, but they aren't fully aware of what's happening. Physical exam. Okay, yes, you may hear a heart murmur, that crescendo, decrescendo thing in the Erb's point, the left sternal border. But it's going to be lacking. And here is the conundrum. When we look at the number of sudden death in, like this study had 387 young athletes who had sudden death. The most common condition that caused it was hypertrophic cardiomyopathy. 26.4% of those 387 athletes that suddenly died was because of cardiomyopathy, hypertrophic cardiomyopathy. The next most common cause is commotio cordis. Does anybody know what commotio cordis is? Yeah, so you get like a blunt chest trauma that grant the vulnerable period of the cardiac cycle that then triggers a life-threatening arrhythmia. If anybody knows the Buffalo Bills player, I think Damar Hamlin, right, 2023, got hit in the chest, collapsed on the field, sudden cardiac arrest. Fortunately, the sports team physician recognized it immediately, started CPR, and he was able to return to playing football like 2 weeks later, 3 weeks later from this. So some random event is the second most common thing that causes deaths in our athletes. The most common thing that causes death in young athletes is something that we can detect if we have the resources available to us to screen these folks appropriately. And that's the conundrum we're in. Okay, let's move on to our last cardiomyopathy, and then we'll be done for the day. So restrictive cardiomyopathy is the last one. Remember, this is a diastolic cardiomyopathy again. And what causes this is you get a non-dilated, non-hypertrophied ventricle secondary to a myocardial abnormality that leads to a stiffening, a fibrosis, or decreased compliance of the ventricle. So this is what kind of separates this from the other forms of cardiomyopathy that we talked about, because there's not a dilation component, there's not a hypertrophy component leading to this diastolic dysfunction. This is, for whatever reason, the ventricle becomes stiff, fibrotic, and non-compliant. So it's not going to stretch to take on that preload. That preload is going to be limited, but it's not because there's a hypertrophy occurring. So idiopathic, most common, but other things, think of like your deposition kind of diseases, so amyloidosis, post-radiation therapy, so like your cancer patients, especially like your breast cancer patients, because you can't really limit the exposure of radiation to the chest, but that's the site that you have to irradiate, right? Loeffler syndrome is like an eosinophilic infiltration. But you can see sarcoidosis, hemochromatosis, all of those can lead to this stiff, fibrotic, non-compliant ventricle. And what ends up happening is you get this diastolic dysfunction where you get that venous congestion if it's affecting the right side, where now you're having that jugular venous distension present. You're going to have all that peripheral edema present from basically that right side not working, right? But then you also are going to have problems on the left side where you're going to have that reduced cardiac output because of that diastolic filling dysfunction that's present. And then that can lead to the exertional kind of symptoms due to that lowered cardiac output. So how are they going to present to you? Well, they could present in heart failure. They could present with arrhythmias because that deposition diseases or whatever that cause this thickening fibrotic disease can then also impact the conduction system pathways themselves, leading to arrhythmias. They may have Kussmaul sign. Remember when we talked about Kussmaul sign earlier in block 1? So that is, as you take a deep breath in, the right ventricle can't handle that extra volume coming back to the right side of the heart, and you see your jugular venous pulsation wave increase. It should decrease when you take a breath in. They may have JVD, may have S3, may have S4 because you have that stiffened, non-compliant ventricle. Remember, S4 is that atrial kick, and because of that stiff, non-compliant ventricle, it's like that jet of blood leaving the atria runs into a brick wall. EKG. The classic finding on EKG for this restrictive cardiomyopathy is a low voltage EKG. Because now you have all of this extra tissue, all this extra fibrosis, all this scarring, and all this kind of stuff that's interfering with that detection of that action potential, that electrical activity, from being detected by the EKG leads. So you're going to get a low voltage EKG. Chest X-ray may be normal. If they're having that heart failure, you may start to see the pulmonary venous congestion associated with it, but not anything specific to this disease. On echo, you might see what's called a starry night or a speckled pattern. So starry night or speckled pattern. Because what you're doing is you're seeing all that fibrosis or amyloidosis or whatever those things added to the the myocardium. You're detecting that thing, and it's not a normal myocardial look, so you get like this speckling kind of pattern, and it shows up differently on the echo. So you may get that finding on your echo. Cardiac MRI is actually important in this case because you want to differentiate this from constrictive pericarditis. So remember, constrictive pericarditis was that stiffened pericardium. So is that dysfunction we're seeing, that lack of compliance in the left ventricle, due to the pericardium being stiffened and not compliant, or is it the ventricular wall, the myocardium, that's the problem? So the cardiac MRI will help you differentiate between the two. Doing a biopsy may also be important because it's going to help you differentiate what specifically is causing this condition. Is it sarcoid? Is it amyloidosis? Is it a eosinophilic infiltration like you see in Loeffler syndrome? The treatment for it? Well, let's reduce the preload carefully, because we already are having a filling problem, right? We don't want to wipe out our preload. We just want to get rid of some of the excess, the overload that could be developing because of that filling this defect. So, so using diuretics sparingly but carefully watching them. But let's definitely reduce their afterload, because I want to get as much of that volume of blood that actually is getting into the left ventricle. I want to get that out. So maybe I would be able to raise my EF from 50% to 70% and just get more volume out. Let's do anticoagulation if they have arrhythmias, because we don't want them to develop a thromboembolic event. And then ultimately, these are not reversible causes necessarily. So if they've developed this condition, it's not going to get better. So these folks need a heart transplant. And unfortunately, to end this lecture on a sad note, prognosis of this without getting a heart transplant is this is only going to get worse. It's only going to progress. It's only going to have worsened diastolic dysfunction, which means they're going to have worsened physiologic states, which means they're going to have worse symptoms, which means their quality of life is going to decline. And without a heart transplant, the average survival is only 1 to 1.5 years after diagnosis. It takes maybe 4 years to get a heart on the transplant list. So a lot of these patients are going to die waiting for that heart to come available. All right.